Good morning, Dr. Khoury. Thank you so much for joining me today on this wonderful interview. I really appreciate having you here. How are you doing today?
I'm doing great. Good morning, and thank you so much for inviting me. I'm just excited about just being able to give some information about wound care and very happy to be here with you.
Yeah, you've been so instrumental in my own personal journey. And so I'm so excited for us to share more with others about what's been going on and all of your amazing skills and tools that you've shared with me. But before we get started, would you mind just sharing a little bit more about your background so that we can just know more about you?
Yeah, absolutely. And it's very rewarding for me to be able to take care of, somebody and see progress and improvement. So my experience really with wound care is started in emergency medicine. That's really the area that I specialized in and worked in for quite a few years and kind of fell into the wound care field when a hospital that I worked for decided to open up a wound care center, and they wanted it staffed by physicians that had some wound care experience. And so it really has been a process which started about 16, 17 years ago when I started working within the wound care space. And it's been very rewarding for me just to see not only the need that quite a few patients have for specialized wound care, but also obviously, for me personally, just to see patients progress and improve with time, because it is kind of its own little area where it's fairly focused. And there are quite a few different providers that do some wound care here and there, but I think the difference is mostly related to specializing and focusing on somebody's wound and doing everything possible within like the scientific knowledge to help their wounds to progress and improve. And so yeah, it's been an absolute pleasure to take care of you and happy to give any knowledge I've had and gotten over the years related to care of patients with wounds.
Awesome. Thank you so much. Yeah. And just a little background on me for those who haven't met me before. So my name is Christina Courtney, and I had my first thyroid rupture in 2023, actually, and I did not even know that wound care doctors existed. And so it was actually that physician, it was his first rupture. It went undiagnosed for a couple of months until the tissue literally started protruding, and we had a wound care nurse, but it was nowhere near the level of care that I've had this time around with this rupture with you. So I'm just to emphasize that this I know from firsthand experience of going through a rupture without wound care physicians and going through a rupture with wound care. It's just literally night and day. And the comfort, the recovery, the interventions, the knowledge, and not only the physical intervention that is taking place, through having regular appointments with you, but also I think from a patient perspective, just the comfort of being able to know that you can go to somebody who understands your situation and is knowledgeable about it. Because as a patient, when we have a complication in our physical body that we don't know what's going on, how to fix it, and then our doctor doesn't know what's going on or how to fix it, it's
Yeah,
scary. And so
yeah,
I think even my mental health and going through it this time around and just mental emotional well-being, just knowing that I have a physician that knows what to do, knows how to care for it, has made a dramatic impact. So if there's any patients watching going through that, I just want to validate them in that experience. It just can be so helpful on all levels to have your background. So thank you again.
absolutely. Yeah, no, it's a very complex case, and I can definitely see that having somebody that another set of eyes. You have quite a large team of very knowledgeable physicians, and even though I'm by no means an expert in like thyroid, your specific situation with thyroid capsule rupture, but just some of the basics with regards to infection, wound care, knowledge with regards to things like dressings and topicals that can be used, and potentially oral antibiotics, and even some of the different providers that may be helpful to be involved in your care too. That's something that could be of use and value. So yeah, I can definitely see that, and I was happy to do what I could to help.
Thank you. Yeah. So I want to get into all the details, but before we do you want to just give a little disclaimer? Make sure
Yeah.
that.
Yeah, absolutely. So basically, um, I did have consent from you to discuss this in a group forum. And the other disclaimer is just I'm speaking out of my own, personal experience of your specific case. It's not intended to serve for medical advice for others. And please consult your own provider to evaluate your own case individually. So there it is. That's the disclaimer.
Thanks.
Yeah, sure.
Want to keep everybody happy.
Yeah.
So, so then going into, just really understanding wound care and, why it's so important and, what other people may not know about it. So how, in your words, how would you say that wound care is different than the care that we might receive from our primary physician or even, in thyroid rupture specifically, most patients who have a rupture, it's rare, and oftentimes it's their physician's first time dealing with a rupture. So they're they have no information, don't know what to do, and there's not a lot of training. And so, how is your specialty in wound care different than what other physicians are trained in, and how is it able to really benefit and complement this situation?
Yeah, no, that's a great question. I think, your case is very unique, and honestly, I'd never seen a case like yours before with regards to this type of wound and a thyroid capsule rupture, and also, some of the complications like this are exceedingly rare. But in general, for wound care, it's different than a lot of other providers, mainly because we're just focused on wound healing and have a little bit added knowledge with regards to how to treat wounds properly to get them to progress towards healing. So we tend to see the more complex cases, even though I hadn't seen your particular condition before. We've seen a lot of different complicated wounds from various causes. And so we've gained some knowledge with regard to what is the best evidence-based treatments to get the wounds to progress and heal. Um, Also, there is more of a focus on the wound itself. I think with primary care and other physicians that are, performing their active, duties, these are things that are more focused towards, everything that can be done towards improvement and creating the condition to help the wound to progress and heal. So I guess it's mostly just the focus on the wound itself, the surveillance, which is a little more. I would say that typically on a weekly basis, we're reevaluating the wound, measuring it, seeing if there's any signs of infection, seeing if any topicals applied to it are going to be helpful to get the wound to heal, dealing with things like infections, or we call it heavy bacterial bioburden. So if there's an increase in the amount of bacteria that's accumulated on the wound itself, are there topicals or sometimes even an oral antibiotics that would be beneficial to help with healing? So it's kind of a long answer, but essentially it's more of the focus and the surveillance is, and the knowledge base is probably what distinguishes somebody that does wound care primarily rather than either primary care or other physicians that, do other things.
Okay. Awesome. Yeah, so helpful. And speaking of wound care, so what would you say are the common misconceptions then among both patients and physicians when it comes to wound care? Because I had a lot of misconceptions going into it. There were, in even some of my physicians in the past, love them. I think all of my physicians have been amazing, but one of my first ones had recommended, airing out the wound. And then when I talked to you about that, I just, recognized that it made so much sense why that may not have been the best thing to do. So I just wanted to see if you could address some of the common misconceptions around wound care.
Yeah, I think the big one is just what you said. Probably the number one misconception would be allowing a scab to form on the wound, which, I think probably the majority of people would say, that's a good thing for the wound and they want a scab to form. And it may be for most people, that's an indication for healing. Like this is a good thing. The reality is, and there has been, studies that have been performed regarding this in particular, but allowing a scab, especially a hard scab, to form on the wound is actually detrimental to its healing and reduces healing capability. So whenever we see a very hard, we call it fibrinous exudate, or another term is slough that's used, SLOUGH. So when that forms and it becomes quite hard and it reduces the capability of the wound to fill in with healthy healing tissue, we call that granulation tissue, and it reduces the capability of the skin that would naturally migrate over healthy tissue to get the wound to close. And so there is a significant delay in healing when a hard scab forms on the wound. I would say that's probably, the first thing that most patients would question as to why are we keeping the wound covered. There's another added couple things to that. One is we do like the wound to stay at a certain temperature, at a warmer temperature, and when the wound is exposed to the air, the temperature around the wound drops. It actually reduces healing capability, and also just to prevent infection from developing. There's quite a bit of bacteria in the environment, and the wound will get exposed to bacteria from the skin around and from the environment if it's open. So it's not optimal to have it open to air. On top of that, we do have specialized dressings that are used that are good antimicrobials to reduce the risk of infection. So it's definitely nice to have something on the wound that's going to keep bacteria from proliferating in the area and reduce the risk of bacterial infection developing. So that's probably one of the primary things, is just proper moisture control, not getting the wound to dry out. And there's the other end of the spectrum too, is it could be too wet and too moist, and that also could be a problem. So that's where I think dressings and how frequently they're changed makes a difference.
Yeah. I'm still learning new things from you. This is awesome. I thought about temperature.
Yeah, yeah.
And so when you said the about scabs, is that for all scabs? Because I'm thinking of, falling over and scraping my knee and the scab forming. Are there different times when a scab forming is good and then different types of wounds where a scab forming is not good? Because, for example, in my particular case, right, is the thyroid nodule rupture. And so the capsule of the thyroid has opened and tissue is actually protruding. And then also the fluid, like thyroid juice, or I'm sure there's a better medical terminology for it, but
Yeah.
it's in that situation. How is that different than a scraped knee? Can you talk a little bit about that?
Yeah, so you have a very, very unique and different case. And so this is, you basically formed a tract that's going, directly from the thyroid gland to your skin with thyroid tissue that's coming out. So, but actually, what's coming out is not a scab. This was actually thyroid tissue, and also a lot of drainage related to tissue fluid. So we call it like serous drainage that's going to come out of a wound naturally when there's an opening in the skin. So this is a little bit of a different and unique case, but I would say typically with most wounds, and then I usually tell patients, many wounds and generally most wounds will heal just fine with a scab. And when we're young and we scrape our knee, a scab forms and it heals underneath. A couple factors. One is usually when we're younger and we skin our knee, that the depth of the wound is pretty minimal, and so we don't have a very deep wound that needs to produce a lot of tissue, and the skin can migrate underneath that scab just fine. So wounds definitely can heal very nicely with a scab in place. I think a couple things. When we get older, and if the wound is deeper, then suddenly we need to produce tissue we call granulation or healing tissue, which kind of looks like meaty tissue that needs to fill in the wound. And that's really where we get a reduction in the capability to produce healthy granulation tissue when we have a very hard scab that forms in the area. And then also just the skin migration. So once the wound is filled in, we actually have epidermis or skin that's going to actually grow and migrate over the wound. And if we have a hard scab that's there, that's going to reduce the capability of that skin to kind of grow and migrate over the wound. So I guess the short answer would be generally for most wounds, we don't really want a hard scab to form. I don't see any benefit of that forming for any wounds really. Even for a scrape and a knee, it's better to have some type of an emollient put over it or a dressing covering the area to soften the scab, because that will help and improve the healing or the speed of healing. And I think that becomes more important once we get a little bit older, and if there's more depth to the wound too. So there's really no real benefit of having a scab form. There are situations I should mention where the wound is overly moist, very wet, and we have a wound that's heavily draining, and we do want to dry it out. So we definitely don't want an overly moist wound where we see what's called maceration or fluid that sits on the skin, causing it to sometimes even break down. So in that scenario, there are periods of time where I could have patients expose the wound for a period of time to dry it out. So those are more extreme circumstances. But in general, a scab is really, or a hard scab, I should say, is not really a good thing for the wound.
Okay, so interesting. And is it also because of infection risk too? Does that have something to do with why you also want to keep it covered?
For sure, yeah, absolutely. So whenever it's exposed, definitely bacteria can migrate into the wound, and there's a lot of bacteria, in the environment, of course. So it's very easy for bacteria to sit on the wound, and then our main barrier to prevent infection is our skin. And so when that's lost, and now there's a direct connection for the tissue underneath the skin and the environment, it's much easier for that infection to develop, especially in somebody that's immunocompromised, if they're on steroids or if they're diabetic, they have certain immune conditions. So it makes them more likely to develop an infection if that skin barrier is lost. So we're really trying to do everything we can to just try to protect that bacteria from, sitting on the surface and migrating inside. And if it's exposed, the risk of that happening is higher.
Yeah, I remember you shared a fascinating statistic with me once around the chances of a wound getting an infection after a certain period of time of being open. Do you remember what that stat was? It was so interesting.
Yeah, so I think, the longer it's open, and I don't know the specific numbers, but the longer that it's open, for sure, the risk of bacterial bioburden accumulating on the wound and turning into infection starts to ramp up because bacteria essentially just accumulate, especially in a scab itself. We have this, it's essentially not, it's devitalized, not vascularized, a film. We call that biofilm. And so when that biofilm, it's almost like a starch matrix, is probably the best description of what it actually is. And then we get bacteria that accumulate and sit in that starch matrix or biofilm, and it just accumulates as time goes on. It's not something that's going to go away unless something is used on it, like cleansers or antibacterial dressings. And as it accumulates, it definitely ramps up the risk of bacterial infection because just the quantity of bacteria that's sitting on the wound surface goes up. So yeah, again, it's one of those things where we like to try to eliminate that biofilm if possible
Interesting.
through various methods. One would be debridement. So you have a very special case that's a little bit different, but as in general, we try to do is debride or essentially mechanically remove, if we can, the fibrin, which includes bacteria and that starch matrix, off of the wound bed itself, cleanse it, and use antibacterial dressings. And this all reduces the risk of that bacteria accumulating and an infection developing. Your case was very different because you had a very pinhole opening, really a fistulous tract that was going from your thyroid out. So a lot of the things that we typically do for many wounds, we can't do for yours just because of the cause of the wound and just the fact that this was more of a tract that had formed
Uh,
that came up to the skin rather than a typical open sore that we could debride mechanically.
okay, interesting. And so still on the topic of these misconceptions, I think this is so helpful. The common one for me as a patient was that keeping it open, and I think for physicians too. But I'm wondering, is there anything else that, as you were going through med school, because you went through the traditional and then you transitioned or expanded, I should say, in
Mhm.
wound care, was there anything that you wound up learning once you expanded into wound care that other physicians watching this may not know or may not have learned in their traditional foundational training?
Yeah, I would say just some of the routine protocol, for wound care in general, and I would say a lot of things that I learned are related to, moisture control, the various dressings that are optimal to use for wounds, depending on, reducing the bacterial bioburden and the specific bacteria that we find on the wound beds and how to reduce that. Moisture control, how to prevent damage on the skin around the wound from moisture, and then just frequency of dressing changes. And a lot of other things are just kind of more specialized treatments that we do for some patients, like negative pressure wound therapy or wound vacs on some patients, or sometimes we'll use, they're called bioengineered dermal replacement products or tissue products to help, kind of like growth factors to help with healing too. So there's a lot of those types of things that I really did not work in that realm, was not knowledgeable about at all.
Okay.
Um, Essentially just a lot of things associated with, trying to improve the healing capability of the wound outside of just, applying something topically like Neosporin, which is commonly used.
Yeah. Okay, fascinating. Well, that's good then, because we're going to get into that shortly. So,
Sure, yeah, sure.
so I want to get into all of that, all these wonderful tools that you've brought to the table for me. But before we go into that, I just want to kind of maybe set the stage for where you met me and then how you assess a thyroid rupture wound and the process for all of that, and then what you recommend based on that. So, just to give the audience a little background, so I initially ruptured during an RFA procedure in February of 2023 with a physician in Orange County. And at the time, we didn't know that I had ruptured. I just had a lot of pain afterwards. It wasn't until a couple months later, I went to another medical facility for a second opinion that we finally diagnosed that, yes, in fact, this was a rupture. And at that point, the tissue was actually starting to bulge and actually starting to protrude through my skin. And it was very painful. So I then went through like an additional 5 months, I'd say, of trial and error of just trying to figure things out before it eventually closed. And then fast forward about a year, year and a half, I met another phenomenal physician that I went back to have a repeat RFA, hoping that everything had healed and it wouldn't happen again. But that track that was initially formed, even though we were very cautious during that second RFA procedure, that initial track was still there. And so it wound up opening about a month after that treatment. After that, I wound up having a series of other treatments that were really helpful, like a thyroid embolization. I've actually done two of those. I've done several NSPFA treatments in lieu of RFA that have been really helpful. And so while I've had this open wound essentially on my neck and dealing with that, I've also still been able to go through treatments to continue to reduce the size of my thyroid nodule. And so going to when I met you, I think it was about a month or two-ish into my open wound journey. This time around, when the original thyroid rupture reopened almost a year ago now, last summer. And so when I came to you then, and you're seeing this for the first time, what are the things that you're doing to like evaluate my case and see, is it healing? Is it not healing? What are the things that you're looking for during our appointments and all that stuff? If you just want to kind of, walk us through that process of the interventions that you do and how you're looking at my unique case.
Yeah, absolutely. And your case is definitely unique. So just, I think I told you this, but I've never seen a case like this before. So this is completely new. But I would say a lot of the basic principle of wound care, that are provided are going to be the same for this, like for other wounds too. So in your case, essentially just having a connection between, your thyroid and your skin. So essentially, that connection allows material from inside to come outside. And like you've discussed before, you had some thyroid material that's coming out of this tract that's forming. And so I would say the initial concern with me, and I think with other doctors too, is there any infection that you have internally in your thyroid gland itself? Do you have any infection or an abscess or a pus pocket, anything like that that's internal that needs to come out or needs to be expressed? So that's probably the biggest thing that could be more dangerous, I would say, for sure, because of the location, obviously, of your thyroid gland around your airway and blood vessels. And the fact that if you do have any infection internally, that needs to be treated through whatever means necessary. So including things like antibiotics, or if you have an abscess, potentially even like surgical drainage. So I would say that's, the first thing on my mind would be, is there any internal infection that we're dealing with here? Or is this just the connection between, your thyroid gland and the environment and your skin?
Okay.
Um, the second thing would be just what are the best ways to control the moisture in the drainage that's coming out, including the thyroid tissue, but also just tissue fluid drainage. We call that serous fluid that's coming out because actually fluid sitting on the skin can be quite damaging. So usually we'll see a couple things. One, we'll see very commonly, we call it moisture-associated skin damage, which is essentially moisture sitting on the skin causing it to become inflamed and irritated. So it'll look actually sometimes like infection developing on the skin around. It'll be red. It could look white in color as well, just from all that moisture sitting. And it could be itchy. Sometimes it could be tender as well. But we know a lot of times this is really related to moisture from the wound because it's sitting right underneath the dressing and it becomes inflamed. And when it dries out, if we're using the proper dressings or protection on the skin, it just improves dramatically over a relatively short period of time. It could be just a matter of days after we protect the skin or change the frequency, increase the frequency of dressing changes, that improves. So the things I could control, and you had, other physicians that were monitoring, which made me feel a lot more comfortable, of course, because I'm not an expert at all at this. So, but the things I could control basically would be how to control bacterial bioburden on the skin surface, do an assessment to see if there's any infection, that you do have, and then just what are the optimal dressings to use externally. So we needed something very absorbent, we knew, because you're draining really heavily. So we're talking about our most absorbent dressings. And secondly, we need something to protect the skin around your wound. And also, you were already doing this because you knew, what to do as far as the frequency of dressing changes. You were changing it very frequently. It could be hours, just because your dressing would become saturated, and you don't want a saturated dressing sitting. So I think those are the things I was thinking of. I would say internal infection. Is there anything else going on there? And then I would say like moisture control and bacterial bioburden control. And then lastly, I mean, you don't have these issues. You're younger, but I think for many patients, we're thinking nutrition issues and immune issues as well. So nutrition issues, proper, adequate protein intake, proper, intake of the amino acids necessary, essential amino acids necessary for healing, and then immune conditions. We see patients with different immunological, disorders and immune conditions where it makes it more difficult for them to heal. And sometimes they're on certain medications, specifically steroids, I would say is the big one, where it just reduces healing capability. So we have to be cognizant of that and know that their healing rate is not going to be, quite normal.
Interesting. Yeah, speaking of steroids, I never knew that, but one of the things that they will sometimes recommend to treat thyroid nodule rupture or to maybe prevent the inflammation is steroids. So
Mhm.
how do you weigh it out? Like if you were a patient, what kinds of things would you be thinking about weighing out? Should I take steroids or not take steroids? Do you think that they could be complementary for thyroid nodule rupture, or do you think they could get in the way of the healing? Usually it's a shorter course, I've heard. And
Mhm.
of course, I'm not an expert either, but
Yeah, absolutely. Yeah. So, and again, I'm not an expert at this either, but I can tell you as far as a wound is concerned, generally steroids are not helpful for healing at all, and they increase your risk of infection as well. So, we prefer somebody not to be on steroids if they don't have to. Now, many patients, they have to be on steroids, of course. They have certain immune conditions, and if it's going to help, your thyroid, condition itself, which many times it will, then for sure we don't, obviously we have to live with whatever steroid that somebody's taking. If it's obviously preferable for a shorter period of time and then stopping it, and then suddenly your healing capability, comes back again, after that or improves, after you stop your steroid, that's preferable over somebody on chronic steroids where they're taking dosages every single day, consistently, and especially higher doses. We know that definitely does reduce healing capability. There are exceptions to that. There are certain immune conditions that are quite rare, where there's so much inflammation in the body that steroids do help the wound to heal. This is quite rare, and there are a few that we do treat with steroids, but this is not a common scenario. The vast majority of regular open wounds, including yours, if you're on steroids, it's not a benefit with regards to healing. It does a couple things that are negative. One is it increases your risk of infection whenever you're on steroids because your immune system is suppressed. The other one too is generally if somebody's on steroids, there's the second phase of healing is called the inflammatory phase, and it blunts the inflammatory phase. So to produce actually tissue, you actually need inflammation, and you need the immune system. And if this somebody's on steroids, then basically your capability to produce, antibodies to help with production of granulation tissue in that inflammatory stage is blunted. It's going to delay healing in general. So again, for a short time being on steroids, it's fine. It helps, your particular condition. But
Mhm.
for most, if they're able to minimize their use of steroids, that would help with their healing. So we basically sometimes will work with somebody's, it could be their endocrinologist or rheumatologist to try to bring down their steroid level to just what's absolutely necessary and not more than that, because we know that that's going to improve their healing.
Interesting. I had no idea about that. And I don't even think I've mentioned this to you, but after I did the second thyroid artery embolization, I was actually on steroids for 3 days because one of the things that can be common in embolization is it's like I forget the name of it, but it's like post embolization syndrome, where you
Yeah.
kind of like get like these flu symptoms. And I had had a little bit of that the first time around, and I didn't take steroids. So the second time we put me on a super low dose, but it was just for a few days. And I didn't even think that I should have told you that I was doing that.
Yeah, yeah. And again, for a short time like that, that's not a big deal.
Okay.
And actually would help with the soft tissue swelling right afterwards too. The concern is mostly for somebody that is on it chronically, especially higher doses. So for a short time, it's usually not a big deal. It's definitely not something that it would, probably would benefit more than harm just because it'll help with soft tissue swelling, after the procedure. But if somebody's on, prednisone, it's usually somebody that's on a daily.
Mm.
And again, if they're on higher doses, that's when we get more concerned and know that this is not going to heal as quickly because of that.
Okay, that's so interesting. So it's kind of a case by case basis then.
Yeah,
You
yeah,
evaluating all the different things going on for each
yeah,
patient. That's fascinating.
yeah,
Okay. So I come in for you for these weekly appointments, and we're checking my wound. You're evaluating the moisture, how often we're changing it, different interventions. I'm wondering if we can go through just the different products and just kind of like the do's and
sure.
don'ts of them, like what kind of routine you're recommending as we go through these different products.
Yeah, yeah, absolutely. So, do you want to just talk about the types
Yeah,
of products that we use? Yeah. So I
yeah.
think, the main thing we're looking at, it's pretty basic. I mean, I try to break it down to like, simple stuff, but I would say the first thing would be proper moisture control.
Mm,
So we want something, if the wound is very dry, we want something that's moisturizing. In your case, you had a very, very wet wound because it was draining heavily. You had, tissue coming out along with a lot of drainage coming out, from the soft tissue, and a lot of this we call it serous tissue, which is tissue fluid that's coming out. And so, because of the amount of drainage, we wanted to use our most drying dressing. We had to use something that's wicking away the moisture. Even with that, we had to change it frequently. So, how do we control the drainage the best possible way and keeping it covered? It would be our most drying dressing and something that's changed as frequently as necessary. It could be 2 times a day, 3 times a day, 4 times a day, and that's not usual. Usually we're changing dressings much less frequently than that, but because of the amount of drainage, it required that. So those are, as categories, the most, I would say, absorbent type dressings that we use are called hydrofiber dressings or alginates. So they frequently are combined with silver because silver turns out to be a natural antimicrobial kind of broad spectrum. It's not an antibiotic, but it definitely goes back many years in its use. But basically, ionic silver does help reduce. the capability of bacteria to proliferate and grow. So it's actually a pretty good antimicrobial to keep bacteria from accumulating on the wound bed. So frequently we'll use things like silver alginates or silver hydrofiber dressings for very moist wounds, wounds that are draining heavily. Secondly, we want something that's going to protect the skin. So the second concern in a heavily draining wound is the skin around it. Is it getting damaged or irritated, inflamed from all that drainage sitting? So we want to, there's different methods of products that can be applied to the skin to protect it from moisture. And I would say the common one are zinc-based pastes. So I would say similar to the concept of Desitin that's used for diaper rash, but basically there's quite a few products out there. The one we use is called calmoseptine, which is zinc oxide, and it has calamine in it to help kind of soothe some of the irritation as well. And so that's applied on the skin around the wound, and it really just forms like an occlusive, I guess, covering on the wound. So when moisture gets on it, it's not really going to soak into the skin itself. And then the other one are barrier films. So it could be various different types of barrier wipes that are used on the skin around to protect the skin from moisture, again, sitting on it. So for you, the zinc-based paste calmoseptine did really well to reduce the irritation and the moisture damage, you know, or even sometimes people are allergic to dressings too, or develop allergic reactions or contact dermatitis from the dressings. That'll actually protect it. We obviously want to change the dressing if possible to something different if that happens, but it'll also protect it from the dressing itself, irritating the skin around the wound. And then just for bacteria itself, we want to use a cleanser. So, you know, there's many different cleansers out there. The one we use right now is called VASH, VASHE, which is hypochlorous acid. It's a strong concentration of hypochlorous acid. And the concern with the cleansers frequently is, you know, things like hydrogen peroxide or betadine, alcohol. All these kill bacteria effectively, but they also reduce healing capability. So we actually try to avoid those types of cleansers mainly because we call them cytotoxic. They actually kill these good cells called fibroblasts that produce collagen in the inflammatory phase. And we don't want that to happen, of course. So we're using cleansers that inhibit and kill bacteria, but also keep those good cells from dying, allows them to survive and produce tissue the way they're supposed to. So hypochlorous acid is one of those, you know, agents. There's various formulations of that. There's Anicept and Puricin that you can find on Amazon as well, other sites that there are cleansers that are used for wounds just to keep bacterial levels reduced on the wound surface. And then there's surfactant cleansers and many of those, you know, out there, which are quite effective as well, just to reduce bacteria on the skin surface. You can use saline, just the mechanically irrigating with saline will reduce bacteria to kind of wash away the bacteria sitting on the surface. So various different options for cleansers, but mainly we want something that, you know, reduce the bacterial bioburden and also something that is not cytotoxic.
Yeah, that's great. Thank you so much. Because I didn't know any of this the first time around. So I feel like I'm such an advocate for this because I've experienced without these products and then
Yeah,
with these products, it's night and day. Like it literally has changed my experience of dealing with an open wound on your neck. So
yeah.
I pulled some of them out if I can just show people real quick because it was just so fascinating to me. I didn't know that these products existed. Some of my other doctors didn't know that these products existed, and they just were such game changers. So the wound care company that we work with, they'll send me different products every time. So these are like all the different calcium alginates that they've sent me. And they all work pretty much the same, but this is what it looks like. It's kind of like this thicker, it kind of just feels like a thick piece of fabric that I'll just cut to the right size to put right over my wound. And if I go in sequence, though, I should have done it that way. So this is Vosh. This is the cleanser that you were recommending. So I've used several bottles of this. And then this was the other one that I think I had before, but this was the favorite. But then you had also talked about saline. So you can either get saline, one of the companies sent me it in this, and then I would like use a syringe to
Yeah.
drip it down my neck, but these
Yeah.
are a lot handier.
Yeah.
So these are like the little one-time use saline, and so you can grab some like some sterile gauze and then kind of like drip wash it over, which has been great too. And I actually carry these with me. I have like a little kit in case I needed to. When I was changing it more frequently, I would carry a kit of all the little supplies in my car. So if I needed to do a brandage change on the run or forgot, I could just, bust out one of these and clean it and be on my way. So those are so the process would be then cleaning it, whether it's with the saline or the wash. And then I would then apply the calmoseptine. So the calmoseptine, this is the one that you recommended that I'm loving, and it comes in lots of different forms. There's different size tubes or tubs or go packages of it. So we would use a sterile Q-tip that you would also have wound care send me to
Hmm.
apply the calmoseptine around the actual wound, and then you would have me put in the right size, cut down the calcium alginate to the right size, put that right on it. Or the other product that we had experimented with too that I really liked for a while was this Aquacel, it's very similar. It's like the fabric, but it's kind of like in a ribbon. What's the difference between the calcium alginate and the aqua cells?
So the Aquacel is actually a hydrofiber dressing, and then the calcium alginate is in the category of alginate. So technically the hydrofiber dressing or the Aquacel is more absorbent overall than the alginate would be.
Okay.
They're both are quite absorbent, but I would say the hydrofiber dressings can wick away the moisture a little more effectively than the alginates would.
Okay.
They just come from different methods. The hydrofiber dressings, it's kind of like a seaweed based dressing, so it tends to swell. The hydrofiber dressings also, it tends not to stick. If there's a wound that's not draining quite as heavily, it tends to come off a little bit easier. The alginate sometimes, if it's not draining as much, it can sometimes stick to the wound itself, and it could be a little bit painful when it comes off. So I would say overall, out of the two, my preference is the hydrofiber, but both are quite effective. And your wound had been draining so heavily that there was no issue with sticking, probably because of the amount of moisture that was sitting in the area.
That's such an important point, though, because so I'm also the rupture expert in this Facebook group through Jen, who runs a group called Save Your Thyroid, which is
Okay.
patients that have looked for different methods, non-surgical methods to prevent removing their thyroid. So they've
Yeah.
RFA, et cetera. And so some of them, on occasion, when they have rupture, I'll walk them through the process just because I've been through it 2 times now. And that
Yeah.
was one of the questions that a patient asked me recently is that her bandage, she had used the calcium alginate, I believe, but she wasn't draining as much. And obviously every case is different. She wasn't draining as much and it was sticking to the wound. And
Hmm.
she was asking how do I handle that? And she wound up using, I think she put saline over it to kind of loosen it and release it. So is that
Hmm.
what you would recommend? Or possibly she might be better off switching to like an aqua cell?
Yeah, I mean, yeah, I would try to switch to Aquacel if possible. Definitely, if it's coming off with saline, and a lot of times I'll just have patients irrigate it, really liberally, get it really wet, let it sit for a while. Usually it'll come off, so it's fine. I mean, to use that, but I think if there's an issue with sticking, even after irrigating it, it's not coming off as readily or easily, or as painful when it comes off. I would definitely go to Aquacel AG because it tends to form more of it turns almost into a gelatinous, I would say, type feel, and tends to come off easier, yet being more absorbent than the alginate. So, yeah, I would say there's no harm in trying to switch it out to like an Aquacel. Frequently, Aquacel is paired with silver, so it's usually Aquacel AG, I would say, is the most common product out there.
Okay, awesome. So
Yeah.
once you've washed it, we've got the calmoseptine barrier around it, which it like literally, I used to get these massive red rashes in 2023, and I haven't had any of that at all since I've been
Yeah,
working with you, which has been
that's great.
yeah. So we put the calmoseptine around it and then the absorbent material. And then we put a silicone bandage. So this
Mhm.
other thing that was new for me is that I used to get these, my skin would literally peel off because the adhesives in the normal Band-Aids, and because I was doing it for such a long period of time, it was just so irritating. So that really was helpful is when you told me about silicone and how much more gentle they are on your skin. And even, I think, if correct me if I'm wrong, but I think one time you were sharing with me that if it's a low amount of moisture, sometimes you could even leave these on for days. Is that correct?
Yeah, that's right. So actually, for some patients where they're really not draining very much, we keep those on for 7 days, believe it or not, without being changed. And
Okay.
so a lot of times we'll have patients with elderly patients with skin tears, where they have really very little or no drainage coming out of it, but they need something on there just to prevent infection and also just to sometimes keep the skin flap in place. And so we'll leave those on for 7 days at a time, and it's fine. They are, a lot of them are water resistant. They tend to be water resistant. And, the challenge with adhesives is number one is traumatic, injury removing them, irritating the skin when it's on, off, especially when it's changed frequently. So you have an adhesive that's basically, especially multiple times a day, that definitely can be very, irritating to the skin, and also something that stays in place. So a lot of times paper tape is the go-to for many people for like gentler application of an adhesive to keep a bandage in place. But I just noticed from just patient feedback, it seems like they tend not to stay in place quite as well. And moisture tends to get them to peel away easier than the silicone dressing. So out of all the ones, there's quite a few, like we use Hypafix tape as well. And there's quite a few different options, but I would say the silicone adhesives are the nicest as far as I'm concerned with regards to staying in place and also, not injuring the skin when it comes off nearly as much as any other dressings that I've seen.
Yeah. And speaking of tape, so in addition to using these, I also had ordered some of this like silicone scar tape. It comes in a roll,
Hmm.
and I would just
Hmm.
cut it in these like
Yeah,
strips.
yeah,
And
yeah,
so I could put all the stuff around it and then, or, bandage it or dress
yeah,
it normal and then put this over at
yeah.
the little cover. And these are so much more gentle on my skin.
Hmm.
So,
Yeah, I actually have patients do that now as well. In fact, a lot of times those are pretty expensive dressings. The 2x2 or 3x3, 4x4. They're called foam adhesive dressings. So it has a piece of foam in the middle. They are really pricey. I would say they typically cost, you can get them from Amazon, different types of brands, but probably at least $1 to $2, sometimes $3 each. And
mhm.
so if you're changing it frequently, it gets really pricey. So a lot of patients, I'll actually have them get gauze, like a 2x2 gauze, and then get the silicone tape. And essentially they can use gauze or just something that's really inexpensive and just cover it with a silicone roll tape. And there's quite a few out there as well, but that's a great option.
Yeah. And what I've noticed then is since I've switched to using mostly the silicone bandages that don't irritate the skin, I can now use regular bandages. Like this is
Mhm.
the one that matches my skin tone the best. So I do have a regular band-aid because I am going to a function after this. And so I wanted it to look a little bit more concealed.
Right.
So for me, being able to use the silicone bandages most of the time, I can then occasionally slip in a normal bandage
Yeah.
that
Yeah.
doesn't look that is maybe not as
Obvious. Yeah.
appropriate, but it's less obvious, right?
Yeah.
Exactly. So
Yeah.
I can look a little bit more concealed. It just looks like maybe I scraped my neck or something.
Yeah, 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 exactly.
So,
Yeah, I think it's mostly just the regular use of something that's injurious to the skin on and off.
yeah.
It creates kind of a cycle and the inflammation kind of worsens. So once that's calmed down, looks better, you can use something that's a little bit different for sure, that may look, nicer, of course, and more appropriate for certain functions. And it'll be fine because your skin is pretty healthy at that point. So,
Yeah.
yeah.
So I've loved that you've given me all these different options. I can kind of,
Yeah.
use them and, learn my skin, see how it's feeling and adapt and evolved with it. So it's been
Yeah,
so, thank you so much.
absolutely.
Is there anything else about, bandage and how about this? How do you determine the frequency of bandage changes? Because, when I first started seeing you, I was changing them multiple times a day. Now
Mhm.
I can go about 24 hours without an issue. And so how are you determining how frequently we change
So I
bandages?
would say it's mostly just a lot of times it is trial, and error type of situation where in your case, it's really depending on how much moisture is sitting and if the skin is damaged around from moisture sitting. We don't want a bandage that's saturated. If it gets saturated, we want it to change it. So it's really, I kind of leave it up to the patient. If the dressing gets saturated or the skin around is turning white or getting red or inflamed, change the dressing. Yours are really unique. I would say the majority of the time we're changing dressings maximum one time a day, maybe twice, but because of the amount of drainage, this was, again, a special situation. It required multiple changes throughout the day to make sure that the bandage, moist bandage or saturated bandage, not sitting. So it's really just those, and I'll leave it up to the patients to decide on how frequently when there's a really heavily draining wound like that.
Sure.
Yeah.
Okay. And so one other question is so that's like once the thyroid rupture has happened, there's actual leakage. There's also a phase, and you didn't get to see this phase with me, but it happens, and I've had other patients ask me how to support the skin when it's actually rupturing. So what to kind of walk through the process and my understanding of it, and please correct me if I'm wrong, but it's almost like the capsule of the thyroid at some point ruptures, whether it's during the procedure or some sort of activity afterwards, where the capsule will rupture and some thyroid tissue or fluid starts to leak outside of the capsule. But then it takes a little while for it to build. And often patients have like this lump or a bulge on their neck. And then eventually it breaks through the skin. And that 24 to 48 hours it's breaking through is really painful. And the skin looks really raw and it can get like flaky and be very sensitive. And so, unfortunately, I didn't know you when that was going on. So I didn't get
Yeah.
input, but for other patients, or if this ever happened in the future, is there anything that you could recommend to help with that discomfort and also the damage that takes place on the skin as the tissue or the fluid is like making its way through the skin and causing that initial opening?
Yeah, so this is a question. I don't have any experience, honestly, with this. So this would be guesswork, or just things that sound intuitive to me. So I have no experience with, somebody that's gone through this process. But um, I think a couple things. One is for pain control, there definitely are, different medications that can be used just to control the pain, and I think that's something that all the way from if you can take anti-inflammatories to even like acetaminophen, or painkillers, stronger opioid painkillers as necessary as well. Um, I mean, if there's a lot of fluid inside and that is pushing its way out and it's going to open up, it sounds like it's an inevitable thing that's going to happen. To support the skin, I mean, definitely there are things that can be used, including what you're using right now, like a silicone tape to put on the outside, just to give some support to the skin. But I think ultimately, if there's a lot of fluid that's sitting under the skin that's trying to, work its way out, it's going to open up at some point. Maybe the silicone tape could help just to give it some support on the surface because it is, a layer that's sitting there that's giving it some structure. But ultimately, it sounds like it's something that would be inevitable once a lot of pressure accumulates. It's going to come out in one way or another at some point. It's really going to be a matter of just recognizing it when it does happen, which is what you're helping with, for everybody else, and also pain control. So a lot of times right now, their pain medications are something that are not prescribed as frequently as they used to be years ago, and it's sometimes difficult to get a pain medication prescription like an opiate if necessary. This could be a situation where that's needed, and sometimes seeing a pain management physician, is something that may not be a bad idea because they're experts at controlling pain and they can use a few other types of medications that are sometimes used for pain control that are not typically prescribed by most providers, including like head and neck surgeons or endocrinologists or,
Yeah.
whoever else is seeing you. So,
Okay. Yeah.
Yeah.
So speaking about pain management, that's really helpful. Just to give my own personal experience, it actually was so painful during the action when it was actually breaking through the skin that I was on an opioid on Percocet during that period because I'm allergic to Vicodin. And so Percocet was the best option. And I really only needed it for that 24 to 48 hours as it was breaking through. But aside from that, I really wasn't taking much pain medication in the very beginning when it ruptured and it was internal before I had evolved to the phase of active wound care management. Everything
Hmm.
was happening internally, and that was painful. And I was taking like acetaminophen, et cetera, for
Right.
that. But
Right.
point when it was coming through. And it's happened for me now 3 times, and each time was pretty similar, where it was like just that
Yeah.
24 to 48 hours, super painful.
Yeah.
Luckily, I was able to advocate for myself, and my physicians were open to prescribing those opioids to get me through that period. But if it provides any comfort to other patients, I've also talked with multiple other patients that have gone through that, and it was really painful, but it typically does get better. Like once it's actually protruded and the skin has broken through, the pain significantly decreases, and then it's more like active just management of the fluid and the drainage and the dressing changes and all of that. So
Yeah, that makes a lot of sense. I think it's just the pressure phenomenon, almost like a kidney stone. It's
yeah,
trying to pass, there's pressure. And
yeah.
once the stone passes, not quite obviously a different scenario, but I think once that pressure is released, then suddenly, the pain level drops down. So that makes perfect sense.
Yeah, yeah. And I remember, my one of my physicians once was a little concerned, like obviously you don't want your patient on long-term opiates. So
Right.
that gives comfort to anyone. Like it's usually just for that couple day period and then
Yeah,
we transition out of
for
it. So
sure. Yeah,
yeah.
for sure.
And then while we're on the topic of pain management, there was something that we discovered throughout the process because we want to talk about silver nitrate treatments in a moment. But one of the other things that has been really helpful too that I didn't know about was just lidocaine. So
Yeah, yeah.
when there's some pain on the outside of when it's coming out, I think this was maybe in December, January.
Hmm.
It had closed for almost 2 weeks, and then I had
Hmm.
the procedure done, and it had opened right back up again. And as it was opening, I went through another one of those periods where I needed that pain management, but we actually were alternating between doing the opioid and then getting me off of that and using the topical instead, which was really helpful. And
Yeah,
I don't know why I didn't even think about that as an option, but I remember I went and just got like the over the counter lidocaine
yeah,
spray, which was
yeah.
helpful. So I would just spray it on, and that would help with some of the pain sensation. And then I believe you had prescribed me the lidocaine that you use in your office before doing
Hmm.
silver nitrate. So this one you would need to have your physician essentially prescribe this, but it was really helpful. And so, do you want to walk through like the topical pain
Yeah,
management?
absolutely. Yeah. So there are definitely options to use like a topical anesthetic is really what they are. So they're numbing agents, and we use lidocaine or xylocaine by injection if we're doing like a laceration repair or any type of probably procedure on the skin where it's kind of painful. We're typically injecting the same type of medication. Topically, it does work as well. It works best if it's sitting for a while. So if we put it on and just, within a matter of seconds, it's not going to make as big of a difference if you leave it on for, 5 minutes, 10 minutes, or even a little bit longer, it tends to work. So sometimes for really painful wounds, because we try to avoid opiates long term. So we'll have patients who have, unfortunately pain in their wound over a much longer period of time, and we don't want them to have to take, opiates if possible for a long time, then we'll basically have them use a topical anesthetic cream or ointment regularly with their dressing changes.
Yeah.
So the option usually they're lidocaine, and there's different percentages. It could be 2%, 4%, 5%. There's creams and ointments. The other one I prescribed frequently is called EMLA, EMLA, which is it's by prescription, and it's lidocaine and prilocaine. Prilocaine is a little bit longer half-life than lidocaine, and so that one tends to work well too, just for pain control. And it's again with dressing changes, if it's applied, that's kind of a best scenario if it can control somebody's pain because that way they're not anything systemic. that has all the side effects related to it and makes it comfortable. And for some patients, they'll have pain at certain times of the day, maybe at night when they sleep, it's the worst. And so I'll have them apply it before they go to bed at night and rebandage it then. And if that works, great. And for many patients, it seems to do the trick. So I think that's mainly for pain control topically, it's going to be one of these anesthetics. It's going to be like probably a prescription lidocaine cream or gel or ointment, 2%, 4%, 5%, or EMLA, which is lidocaine and prilocaine, and that's by prescription as well. But you can get over like what you got, that spray is great. That definitely is something that's, obtainable. And they have, just so you know, they do have lidocaine patches for usually used for people that have shingles or pain related to shingles.
Interesting.
So like Salon Paws, has 4%, lidocaine patches, which are cut and applied on the skin. Doesn't work great for an open sore because it's very occlusive. So we need to use a dressing. So I'll typically go to the ointments or creams or gels, but the patch could be used on the skin, for it's actually specifically for people that've had shingles or have shingles, but it could be used for other painful skin conditions as well. And it actually is by prescription, but it's over the counter as well. So a lot of people will just purchase it over the counter.
Interesting. And that's what I discovered about lidocaine is it's over the counter and prescription. And
Mhm.
I prefer the prescription because I could get just the straight lidocaine in the cream. And because the silicone bandages are so sturdy, if I was experiencing pain, I could just kind of peel it back, put a little bit
Yeah,
of that lidocaine on, and then just close it back up. And that would help a lot with the pain management. Whereas
yeah,
when I was trying to use the spray, it's so much harder to spray it. And then you have to
yeah,
and you have to do the whole bandage change when sometimes I didn't really need it. I just needed the pain support. But when I
yeah.
went to CVS and was looking at over-the-counter lidocaine options, a lot of them had like methanol in them or like other
Mhm.
things. And I was like, I don't know if I'm supposed to be mixing
Right, right, right.
lidocaine with
Yeah,
others. So that's
yeah,
an interesting question. If a patient wanted to try some over-the-counter lidocaine, what are your thoughts on if they can only find a lidocaine that has something else in it? Do you think that that would be okay, or should they? Because the spray was the only one that I found over the counter that
right.
didn't have
Yeah.
in it.
That's a really good question, and it kind of depends on the inactive ingredients. And I would have to look and see what's really in there to know that the answer. Sometimes, I mean, obviously it's fine to use on the skin around the wound or on the wound margin, but if it gets inside the wound, which it invariably will, right? Is there any harm to wound healing or any injury or absorption issues of some other product that's there? I would suspect it would be okay. I would have to look at all the inactive ingredients to really know for sure that there would be, an issue with one of them. So I haven't noticed anything from patients. They mostly have used, some things over the counter. It's typically I'll prescribe them something. So it's, fairly few inactive ingredients. It's really just focused on, the lidocaine itself.
Yeah.
But I haven't had any patients have issues with over the counter stuff. So, but I'd have to look at it, I guess.
Okay. Sure. No, that's good to know. And yeah, I wanted to play it safe. I was like, I don't know if
Yeah,
it's gonna
yeah, for
affect or not.
sure.
I was on the right track. Thank you.
Yeah, sure, sure.
Yeah, and other doctors, once you prescribed this to me, and I told my other regular doctor at UCLA, who's phenomenal, he was like, "Oh, I could have prescribed that. We just didn't think about it." And that's the thing
Yeah,
is, because the doctors that are usually initially treating a patient for the RFA or NSPFA or microwave ablation, whatever the treatment is that they went through, they're not trained in the wound care part, so they don't think of
yeah,
these things. But oftentimes you could advocate for yourself and ask for these
sure.
things, and usually physicians are more than happy to support you in that. So.
Yeah, for sure. I mean, they're highly focused, extremely knowledgeable in their area as well. But it's something it's kind of simple.
Mhm.
Um, but it's just because I think with wound care, we're dealing with wound pain not infrequently, fairly frequently on a daily basis. So we're trying to figure out, how to control wound pain and
Yeah.
try to figure out if there's some way of doing it without, having to be on oral medications. And frequently we'll do anti-inflammatories if they can take those. A lot of times they can't for various reasons, stomach issues, gastritis, or they may have kidney problems or intolerance, or they're on blood thinners and they can't combine the two. And then it comes down to sometimes just acetaminophen or Tylenol. Sometimes it requires opiates as well. So, but obviously, these are things that because we see that a lot, we try to figure out what is doable that's least going to cause, problems for the patient. So yeah, I'm glad it worked out. I think it will for most patients.
Yeah.
So they could definitely try that.
Thank you. Yeah.
Yeah.
And so kind of transitioning to one of the other reasons that we've been using lidocaine is for silver nitrate treatments. And so
Hmm.
what I've been doing, so I've had them with you and then also at UCLA with my other physician there who's been phenomenal too. And so what I've been doing is usually when I'm in your office, one of your nurses will clean the wound and then put the lidocaine on while I'm waiting for you to come on in.
Yeah.
And so
Yeah.
that time to absorb it. And then when I'm with the other physician, when I, park in the parking structure, I'll just pull down my Band-Aid and I have my little
Yeah.
and,
Perfect.
and I'll
Yeah.
just, put some on it and then it'll be able to soak in while I'm in the waiting room before I go in to see him. And then he actually will apply some also topically after
Yeah.
treatment. So that's another reason that this has come in super helpful. So
Yeah. That's
yeah.
actually a really good point. And we'll have some patients occasionally because we do like debridements that are sometimes can be uncomfortable. We'll have patients sometimes apply it before coming in, like even an hour before,
Okay.
coming in, just basically, remove the dressing, apply lidocaine, reapply a dressing so it's really can soak into the tissue. And we use it, I used to use it frequently for IV starts for kids. EMLA is commonly used for that. So it's put on, let's sit for a while. If it can sit for half an hour, that's going to work better for sure. So the longer it sits, the better. So doing it before going in for appointments, even for debridements and whatnot, makes a lot of sense too.
Oh, that's good to know.
Yeah,
Okay,
yeah,
awesome. So then kind of transitioning into interventions then. So
yeah,
what
yeah,
kinds of interventions can be done? One of the ones that we've discovered is using silver nitrate has actually been
yeah,
really helpful for me because at least what I've noticed is that when the tissue starts to protrude from the opening, it's a lot more uncomfortable because there's like the tissue that literally has nerves attached to it that are bumping up against the barrier, the bandage on the outside. So it helps with me for comfort when we remove that additional tissue. But then I think it also, from your perspective, I want to hear it in your words, but it helps like to help it to continue draining. And yeah, so do you want to explain
yeah. So I
why you
think
would use silver
again,
nitrate?
this is a very special case too. So this is not a very usual scenario, but when there's this fistulous tract, I guess I would call it, from your thyroid to the skin, and then we have, not only tissue material, but, you know, we have fluid that wants to come out and will accumulate inside, creating pressure. And we don't have a healthy base of tissue there. So we don't have healthy, we call it granulation or healing tissue that's sitting there that we know the skin can migrate over and basically heal in that way, where we have healthy scar tissue, granulation tissue, the skin has grown over that, it's solid, there's no fluid inside, we're all good. We have a situation where we have this fistulous tract with fluid that's trying to work itself out. And what ends up happening is the skin tenuously forms on the surface, but it's not, we can tell that it's going to break open at some point because we can feel it feels boggy, it doesn't feel firm. There's fluid sitting right underneath there. We know that based on the feeling and the way it looks as well. And that fluid is not going away. It's basically sitting inside. There's enough there that the body's not going to reabsorb that. So at some point, it's going to reopen. We don't want fluid if it's accumulating inside to sit there because that's a nidus, we call it, or it's something that could create an infection or an abscess can form. So we want that to drain until hopefully there's no more fluid accumulating anymore, and then at that point, healthy scar tissue forms. So to help keep the tract open, actually using silver nitrate basically burns chemically the tissue that's there, and even slightly inside burns the tissue that's there to keep it open, to prevent a tenuous layer, or even from sometimes drainage that dries on the surface that blocks the exit point. So it essentially chemically cauterizes it or chemically burns the area on the outside to allow fluid to come out that needs to come out. At some point, once the fluid doesn't reaccumulate anymore, and now we have, very minimal to hopefully almost no fluid coming out, then that tract can close. And that way we would stop for sure using silver nitrate. We want the healthy skin to grow over that granulation tissue that's firm, and it can heal properly in that way. So I think it served essentially just to keep the tract open, to prevent premature closure on the outside where there's an internal wound that's really not healed.
Yeah. Okay.
So, yeah.
And could you walk us through the silver nitrate process, like the different steps? So it's basically, we're cleaning the area, applying the numbing to it, and then you're doing the silver nitrate, like using, so this is what, for those who haven't seen it before, these are a few
Mhm.
of the silver nitrate sticks. So I have like the yellow ones, and then there's also these wooden stick version. I've gotten a couple versions. So you're essentially cleaning it, putting the numbing on it, and then I've had it a couple of different ways where then we could put calmoseptine on around it or not. Uh,
Mhm.
and then do the silver nitrate where you're actually, putting the stick into it and essentially cauterizing that skin, if I'm right.
It
And
is.
yeah, and then either if like dabbing it to absorb. So I've noticed that there's like this liquid that comes out with silver nitrate, and sometimes it will like drain and cause like a stain down my neck. So either you dabbing it afterwards and absorbing that extra liquid, or sometimes you'll rinse it with the saline or the calmoseptine all around it too, can sometimes prevent the dripping of it. And then, bandaging it like normal, whether it's putting lidocaine on top of it, then the absorption, and then the either calmoseptine would already be there or applying it again, and then the normal silicone bandage. Is that correct? Like how would you walk through the process?
Yeah, so I think that's exactly right. I think initially you just cleanse the skin or the wound itself with the cleanser. You pat it dry. Um, I think after that, definitely something can be used on the skin around it for protection. Actually, colmoseptine not a bad choice because it'll protect them from any leakage of any fluid that comes out. The silver nitrate, it's very common. You can find it, most places. It's deactivated by moisture. So if we put saline on it, it basically deactivates the process. So after it's done, we want to use something on it just to basically prevent it from continuing to burn locally. And it'll stop at some point just from the moisture, but we want to try to stop it, as soon as we're completed with the process. But yeah, we put something on the skin around would be ideal. After that, there isn't anything set in stone with regards to how long that we apply the Q-tip, to the skin or inside the fistula itself. There's really nothing I've seen with regards to how long you would do something like that. But I think generally you want to do it until it seems like, the tissue looks like it's not, going to survive on the surface to make sure that it's going to open things up. It's more by I think if you do it for 10 seconds or so, 15 seconds, that should be plenty to allow the skin to essentially to be properly chemically cauterized. And then after that, we usually use saline, like one of the saline bulbs, and just rinse it off. And sometimes you'll see some scatter from some of the silver nitrate on the skin around, especially from like irrigating it a little bit afterwards. But yeah, something on the skin like calmoseptine, or even a barrier film or something like that should protect the skin from being damaged around the area. So it's pretty straightforward. I think but there isn't any like particular process I would say that's defined.
Yeah.
But I think generally that's how it's done. Yeah.
Okay. And I've noticed from my experience that it's you're kind of making a judgment call every time, and you're just looking at what does the tissue look like. And sometimes there's more tissue and you
Yeah,
use like two or three of the
exactly.
nitrate sticks and be going for a couple of minutes. And then other times you're just, dabbing it. It's like 10 seconds and you're
Yeah.
done. It's really based, I think, on like how much is protruding and the situation of the wound that particular day, right?
Yeah, for instance, sometimes we've seen if there's a lot of tenting of the skin, we know that there's fluid underneath there, but there's quite a large amount of skin that is kind of tenting, and we want to make sure to get all that skin to open up. We'll do it several times just to make sure that we contact the silver nitrate with all that skin to help that to, come away. Other times you don't have that. It's basically just a tiny little opening that's there. We're kind of cauterizing the fistulous tract itself. making sure that it stays open nicely, doesn't require as long. So yeah, exactly right. It's kind of by feel and by the way it looks rather than anything defined. So yeah,
Makes sense.
yeah.
Uh, the other question I have for you, and we hadn't experienced this together, but I've had it done twice with other physicians, is strangulation. So for
Hmm.
me, in my case, what had happened is the very first time there was so much tissue protruding. I would say it was kind of like at least an inch by inch of like actual thyroid tissue coming out of my neck. And it was like that for a couple of months where I actually had tissue hanging out of my neck. We
Wow,
didn't know what
wow.
to do with it. And I didn't know that wound care physicians existed. And so
Yeah.
I had a nurse that was like, maybe it's not healing. This is not going away. It's not taking care of itself. Maybe we
Yeah.
should try getting rid of it. And so they eventually did try doing the strangulation. And so what they did is essentially put, lidocaine, injected lidocaine in, and then used a strangulation kit the first time around and just tied around it, and we tied it tight, and then within 12 to 24 hours it actually wound up falling off, and it was so much better, and then it could finally start the healing process. And then the second time around, my other physician, he had used like a suture, just a suture that
Yeah.
hospital to tie around it because it was sticking out so much. And so I haven't seen many other patients that have needed this, but if a patient did come to you, if you had another patient who came to you, or if I had come to you sooner and you had seen a chunk of tissue hanging out of my neck,
Yeah.
how would you feel about strangulation as a
Yes, I think that's actually a nice way of doing it. Mainly, I mean, the concern, let's say, cutting it off, let's say, just literally injecting it with lidocaine and taking, a 15 blade and cutting it, or taking scissors, micro scissors, and cutting it is bleeding,
yes,
and so that's the nice thing about, I think, the strangulation method is just, it essentially will take out the risk of bleeding issues if that's done, because it can bleed really heavily and it could be a problem, if it opens up in that way. So I think the strangulation is actually probably one of the safest ways to go,
great.
because that way, essentially, you're eliminating the bleeding risk, and the part that's, obviously beyond where the suture material, or I don't know if they use anything special, it sounds like initially, but even just string or suture material, it's going to lose its, vascular supply, and once it dies, it'll just fall right away.
Mm.
Um, Silver nitrate could be used as well. That actually does pretty good, but sometimes it'll bleed beyond where the silver nitrate is. Like, you know, for really vascular tissue, sometimes we'll use silver nitrate. It stops bleeding. Actually, we use it to prevent bleeding,
Yeah.
or to stop bleeding, but sometimes it'll bleed beyond it. And we have to do it multiple times. Strangulation is probably the safest out of everything. I've never used it, obviously, for this before, but I would say what they did sounds like the right thing. So yeah, yeah,
I love feeling good.
yeah, yeah,
So, okay, so we've gone through what you do in the doctor's appointments and what interventions can be done with a physician. So now when the patient's at home and they're kind of managing it on their own, we've talked about, just playing it by ear on how often they think that they need to change the bandage based on the
right.
moisture. But what about things like showering and if it gets dirty, or what kinds of things would a patient come in contact with when they're on their own that
Yeah,
might need to know what to do with?
yeah. So that's another really good question that I would say different answers will be given by different physicians, different providers, different people. So the studies haven't shown, and they have done studies on open wounds and different types of irrigation solutions, and which ones per se can cause increased risk of infection. So they've actually done studies where they've irrigated wounds with normal saline, sterile saline, with cleansers, actually strong cleansers that we typically don't use as well, and also like hypochlorous, not hypochlorous, like sodium hypochlorite, which is bleach. They would irrigate it with something called Dakin solution, and then they would also irrigate it with tap water,
Hmm.
and they didn't notice any difference in infection rates between any of them.
Really?
So yeah, so I think, as far as taking showers with it open, I don't have patients cover their wounds for shower unless it's painful and it hurts them or they're uncomfortable doing it. And I'll have some patients uncomfortable, like, you know, there is bacteria in the shower. There definitely is bacteria there for sure.
Mhm.
And you're going to get some bacteria from the water that's going to come on the wound. But again, just based on the studies and personally, treating patients, I have not noticed any increase in infection rates when patients take a shower and have water run over it. A lot of times I'll have them cleanse it afterwards with like wash, you know. But just based on that, I typically will tell patients you're free to shower with it open and have water, from the tap going. Now, this is a little bit just based on just my personal experience and from some studies that have been done on cleansing solutions. And it probably depends on where you live and, how much bacteria is in the water. We're living in places where the water is treated. Bacterial levels are quite low. I'm sure there are some places where that's not the case, and it could be more problematic with regards to infection. If there's any concern, keeping it dry would be better, and then just irrigating it with sterile saline or with a cleanser would be the safest, maybe, way to go, especially for somebody that's maybe immunocompromised or if they have other issues where the risk of infection is quite high. But as far as like, a lot of this is based on my own, treating patients with wounds and some studies that have been done. But I would say overall, they're really, I have not seen harm when somebody leaves it open and cleanses it in the shower or with tap water rather than with any of the special cleansers. I'll usually have them cleanse it afterwards, though, if they shower with it open too. So it's not very helpful, but most, I would say, depending on the types of physicians, a lot of physicians will say, no, keep it dry, do not get any water on it, like tap water on it at all.
Yeah.
Some will say shower with it and have it open. I think part of that is that there really isn't like great science behind the advice that we would give. Um, but there are some studies there, and the ones do not indicate that rinsing it with tap water probably, I don't know which area they were, what type of tap water it was.
Mhm.
But anyway, the studies did not show that there was any harm or increased risk of infection.
Interesting. This
Yeah,
is, I'm still learning because hadn't asked you this question directly, but I
yeah,
assume since we were talking about always keeping it covered, that I should keep it covered during the shower. But now I know I don't
yeah,
have to.
yeah. You don't have to. Yeah, yeah. I know.
So I'm learning too. So
Yeah,
that's
yeah,
amazing. And actually, what I would sometimes do is because I thought that it needed to be covered during a shower, if I had like right now, like I have a Band-Aid, say I was going to go hop in the shower, I would actually just throw on like one of these Tagaderms. It's just like
yeah.
plastic
Right,
just to kind of protect it. And so,
right,
and I've also used these when I need to go in for, if they were doing an ultrasound, for example. So if I have an open wound and they were going to do an ultrasound over it, they may not want the foam dressing in between, as they're gliding it, but I also just want to keep it as sterile as possible. And so
right.
I've thrown this over. What are your thoughts on that? Is that okay? Or
Totally, no, totally good and fine. I mean, the Tegaderm is going to be an occlusive dressing to cover it to prevent, any moisture, anything from getting inside, and it's going to protect it from moisture. So I think that's totally fine. Again, for most typical open wounds, there is bacteria in the water, but it's a very low, concentration of bacteria that's there, and it is treated. So for most patients with typical wounds, rinsing it with tap water, I've not noticed any issue at all. It kind of, I would say probably the positives outweigh the negatives, which would be it rinses off some of the bacteria that naturally accumulates on a wound bed, because we have skin that's will have bacteria on it, and bacteria is going to get on the wound bed, and rinsing it with water will probably help, again, just naturally irrigate some of that bacteria away from the wound itself. And I have not noticed any issue or had any problems with or seen any increased, infection rates in patients who are getting their wounds wet in the shower. But again, I would say that's not really something that's known for sure. Like, and obviously, I'm sure in some areas where maybe the bacterial levels are higher, there's contamination or whatnot,
Mhm.
that could be problematic potentially. So, if there is somebody that has either an immune condition or they're concerned about that, or obviously if it's painful as well, I have them keep it dry for showers and then just irrigate with some of the, cleansers or sterile saline, something like that, just to be extra cautious. Reality is we kind of live in bacteria. Bacteria is all over the place. It's going to be on our skin. It's going to be on the wound. So the sterility part of it is not going to be quite be there. Like it's not in an operating room where we're using, betadine, around the wound itself. Everything is sterile when we get inside. It's not really a sterile situation. There's going to be bacteria sitting. Um, we don't want to add any more bacteria to the area. We do want to protect it. But I think, the short answer would be I'm generally fine with, for most wounds, people getting it wet in the shower. Um,
Okay.
yeah.
So good to know. Thank you.
Yeah. Yeah. Sure. Yeah.
So the next thing that patients are really concerned about is scarring.
Yeah. For sure.
So when I ask patients, like what are your biggest concerns? Like how do we prevent scars? And not only how do we prevent scars, like what exactly do we do? So
Yeah. Yeah.
I know you and I have had this conversation before too. And you had recommended this product,
Hmm.
Scar.
Yeah. Biocarnium. Yeah.
Yeah, but I was wondering if you could walk us through like what are the do's and don'ts of I mean, there's gonna, for a lot of patients, there is gonna be a scar, but how could, and it depends on the different situation, and obviously they get better over time, and there's lots of other things that can be done. But from your perspective, what are some of the things that would help in producing?
Yeah. Yeah, I think scarring is very important to try to reduce, any potential, we call it hypertrophic scarring or keloid formation. For some people, they're prone to that, where essentially when the wound heals, there's sometimes too much production of, there's too much collagen and production of a scar that kind of elevates above the wound bed itself. So it looks like a ridge, can be quite firm. Sometimes it'll be really bad, and some people tend to form, really bad scars. And some people form keloid scars, which is actually one that's so severe that's almost like we call it pedunculated, almost like it's on a stalk. But in general, so the silicone type products like that one forms an occlusive layer on the surface to prevent that skin from elevating further above the skin surface. So as it heals from the bottom, especially with an open wound, it has to fill in with tissue we call granulation tissue. It comes up to the surface. Ideally, it's completely flat, and then the skin migrates over that, and it's nice and flat. It stays that way. It contracts over time. It's going to change over a long period of time, but essentially we want to keep it as flat as possible. And so these occlusive type, dressings, sometimes there's silicone scar sheets or gel. They basically form a layer on the surface to try to keep that skin nice and flat and preventing it from elevating excessively in the middle, and to make I would say the overall contour of the wound as desirable as possible to reduce this hypertrophic scarring that can occur. We have to be careful with open wounds, and I don't have somebody use that immediately after it closes with the skin, because if there's minimal drainage that comes through, it can cause real damage and reopen again. So we want to wait for a certain period of time after it heals, the skin matures, gets a little bit stronger, no drainage at all at that point. Then it can be used essentially on the surface just to prevent it from elevating any further. And the wound's going to continue healing for much longer than people think. So it gets covered with skin. We say it's closed, or healed. It's not really healed, 100% by any means. It's going to go from tensile strength about 20% initially once it first gets covered to about 80% in maybe 3 months. That's the maximum. Doesn't get to 100%. And then from there, it's going to continue healing internally. Collagen is deposited, turns into a different type of collagen. It contracts for over a year, believe it or not. So it continues to change internally. So I think, for scarring purposes, the big ones for me are, products like this definitely I think are helpful, but also sunlight exposure. And that's more related to sometimes we'll see this hyperpigmentation, or we'll see the area gets darker if there's UV exposure. So that's why in that particular product, they have like a UV built into it to reduce any UV exposure on the wound bed itself. And so you could also do different products as well, so similar to that, but you can use like a UV SPF sunscreen or something like that as well, just to reduce the risk of this hyperpigmentation. So I think those are the two main things for scarring. Otherwise, the body takes its natural course. If it's someplace under a lot of movement, it tends to want to do like hypertrophic scarring too. So like a neck or a back, or something like that, where there's a lot of movement, and that movement can cause more collagen to kind of form in the area, and it kind of elevates further. So they're at high risk generally.
So how long would you wait then after it? So say after the last day that it's been draining, so it's covered up. How long then would you wait before using a product like this on the scar?
I would say I would wait about a month or so, which is a long time, but I mean, in my purposes, we're dealing usually with like more complex wounds that we want to be certain that they don't reopen again. And so the issue would be if we put that on prematurely and there's a tiny bit of drainage that makes its way through, it causes maceration. It kind of gets a little bit wet in that spot. It tends to want to reopen again. So I typically wait about a month or so, where the tensile strength of the new epidermis is pretty firm at that point and can tolerate, something like that.
Okay. And then for how long then would you use this product? So wait a month until using this, and then how many times a day and for how long would you recommend?
So it depends on the product. Sometimes it's like once a day, or sometimes it's once every 2 days. Like scar sheets could be reapplied every 2 or 3 days, and we'll do it for typically for 3 months or so. So it's a fair period of time, but throughout that period, the skin is maturing, and usually after 2 to 3 months of its use, it's pretty firm, and it's going to be at a nice, hopefully flat appearance. So yeah,
Awesome. That's so
yeah, sure.
so
Okay.
So we could just backtrack for a second to the treatment process, because one of the things we haven't talked about yet is infection prevention and
Yeah,
treatment. And then that's such just a major concern of somebody with an open wound. And often of the physicians too, is that I see, I've also noticed depending on what country, because I've supported patients all over the world going through ruptures, different countries are more likely to use antibiotics than others. Some countries
yeah,
straight in with the antibiotics, and other
yeah,
we never use antibiotics. So
yeah,
so interesting to see the differences. But I would
sure.
like to hear your perspective on how do we, first of all, like notice like the signs. Well, let's start there. Let's start with the signs of infection. So, what would you say are the signs that we would be looking for an infection?
Yeah, I think, typically increased redness, we call it erythema medically, to the skin around the area, which can be confusing sometimes because skin moisture can cause irritation. So, but redness in general, increased temperature, if it feels warm, increased pain, that's another sign too. Things like fevers, chills, those are late things. If somebody's having fevers and chills from an infection, that's kind of a much later sign. So I would say that the first thing would be increasing local redness, warmth, and swelling. I would say those are probably the big ones. And then if we're seeing that, typically we want to do a wound culture to see what bacteria is sitting there. And from there, just antibiotics. Initially, typically, if I don't have a previous wound culture, we'll start you empirically on something, until we get the culture results back.
Mhm.
But typically, we'd like to, give antibiotics, based on what the culture results show. The common one would be Staph aureus. You had a particularly, rare one, or not rare, but not a common one for a wound.
Mhm.
Um, and so we know which antibiotics typically work for most soft tissue infections, and we'll start you on an antibiotic based on that empirically. And then once we get the culture results back, we know exactly which bacteria it is. We know which antibiotic is going to kill it, and then which one with the least side effects, and we kind of go with that.
Yeah.
So that's usually what we do. And then sometimes we'll do some other tests, like in your case, this is definitely more complicated. You had imaging studies, CAT scans that would reveal if there's something internally, like fluid pocket, any signs of an abscess, any signs of even infection. The CAT scans or MRI would show that. So that's an added thing. We're not usually doing that to to determine if there's infection. That's not usually necessary. Again, yours is a special case. And then blood tests and is another one that's frequently very helpful. So a CBC, looking at the white cell count, not a very sensitive marker, but sometimes will go up when there's infection. Inflammatory markers like C-reactive protein and sedimentation rate are both helpful. And then there's one particular one called procalcitonin that's helpful for bacterial infections because it tends to be positive only in bacterial infections and not positive in viral infections. And so when we have somebody that we think has an infection, the procalcitonin can help distinguish bacterial versus other causes like viral, I would say typically. So that's frequently done in the hospital. Somebody's admitted and their procalcitonin level, if it's high, even if it's very high, it's really bad. We know they have a bad bacterial infection or even sepsis. And so they have kind of criteria for that.
Okay. And one of the other things that was done, so I had the infection, it came back a couple of times, and I think initially it was treated with the antibiotic that was just the one that we thought was best for it, but then it
Right.
developed resistance to it. And so when
Right.
later on an actual biopsy of it and send it away to susceptibility, we found out that a different antibiotic was better
Yeah.
for it. So, and
Yeah.
again, my case is more complicated. Hopefully, most patients don't have to go through
Right.
all
Right.
of that. But
Yeah.
there's so many different ways of detecting it. And then if it is something that seems like it's not getting better with the antibiotics, the susceptibility was also really helpful, right?
Very much so. So, like the cultures, there's different methods. Like a swab culture is one. The best is a biopsy. So the biopsy is actually tissue. That's going to be the most accurate to tell whether or not there's actually an infection versus what we call colonization, which is bacteria sitting there but not really invading the tissue or causing, a true problem. And the infection obviously necessitates usually systemic antibiotics. Colonization does not. So that's something that could be treated topically, typically with some antimicrobials. So, but yeah, the quantitative biopsy is like the gold standard, with regards to deciding whether or not this is truly. And then these sensitivities tell us definitively this kills it or doesn't. That way we know for sure if we're starting on something, this is going to take care of it, rather than more guesswork based on the type of bacteria that we're seeing. So
Yeah.
yeah, yeah,
And actually, so the other thing I want to talk about is when to refer to an infectious disease doctor, because that was also really helpful. And I
yeah,
work with one, and they put me on this metronidazole gel, which is like
yeah,
ointment on the outside. And which is interesting, the very first time I had the rupture before I was working with a wound care physician, it was recommended at some point to crumble up metronidazole and actually put it in.
yeah,
And so that person just didn't know. I'm assuming that there was an actual cream version of it, which was
yeah.
so. So in your opinion, then, when do you think it's really helpful to get an infectious disease doctor involved in
Yeah,
the?
I think, for, I would say, complicated infections, you would qualify for that. So if there's something that it's unclear whether or not there's an infection or colonization or bacteria that is not the run of the mill, something that is more atypical. Um, the other thing too that's helpful for is the infectious disease doctors are, obviously going to be more knowledgeable with regards to treatment with antibiotics, for a longer period of time, especially if there's a risk of recurring infections.
Yeah.
They, we're knowledgeable of side effect profile and whatnot, but they're very knowledgeable about, side effects and which ones are better tolerated. Um, and also, I would say the other one is sometimes we don't have oral options, and they need IV antibiotics, and we put in what's called PICC lines, which is it's a line that stays in for sometimes up to 6 weeks for bone infections and whatnot. So they're the ones managing that. They're doing IV antibiotics for patients all the time in the hospital and even as outpatients too. So I'd say more complicated infections, the ones that are more exotic or different, or situations, types of wounds that are not typical and they require potentially antibiotics to help guide whether or not it's truly needed or not, and evaluate maybe the blood testing to determine that as well. And then also like IV antibiotics for some too. That's usually when you refer out to infectious disease. They're usually very helpful. They tend to err on the side of no antibiotics.
Yeah.
compared to most physicians. I have seen some that it goes the other direction. They
Mhm.
tend to, prescribe a lot of but I'd say infectious disease doctors tend to not prescribe antibiotics as much. They'll want to shorter courses or not prescribe altogether. Yeah, yeah,
Yeah, which I thought would be the other way around, but it was really
yeah,
interesting that, yeah, they're a little bit more cautious. The only
yeah.
thing is, like, I think the first time around when you had referred me to the infectious disease physician, is she just increased the dosage. Like, she recommended the same thing. So it was just like
Mhm.
little tweaks,
Right.
which was interesting. So it was just so helpful. I've learned so much through this process and just how helpful it is to have all the physicians on the same page and kind of like working together and like
Absolutely.
this
Yeah,
comprehensive team. It's just been amazing. I'm like
yeah,
so grateful that you've been so willing to work. I know you've even spoken with my interventional radiologist at UCLA and
yeah.
with my infectious disease doctor, and I'm just so appreciative of that approach because, we all have different pieces of the puzzle that we can add to it.
Absolutely. Yeah, no, that's 100%. I mean, I think that's the ideal in medicine, which doesn't happen a lot of times with just having multiple different types of, physicians, providers that can communicate with each other, and try to provide like the best care. And so, because each person has expertise
Yeah.
that others don't. So I think some particular knowledge in certain areas that others don't, and just the collaboration between everybody, I think gives the best type of care possible.
Yeah, absolutely.
Yeah. Uh,
Um, so for patients though that don't have access to wound care, like do you have any recommendations for that? Like if somebody doesn't have a Dr. Corey, like I'm so blessed that I have you and my other physicians. But if a
Thanks.
patient didn't have you, are there any recommendations that you would give them for navigating through this process?
Yeah, there are some online resources. I mean, definitely like primary care. It kind of depends on the primary care provider, but there's a lot of primary care that are quite knowledgeable, and usually they're going to do a lot of the same types of things that we would do. The one things they tend not to do as much of, if necessary, would be things like debridements for wounds, or even like compression, bandaging, things like that, or some of the advanced treatments. But I think for like basic stuff, they definitely can do cultures, antibacterial prescriptions for different types of ointments or creams, act oral antibiotics, based on the cultures that are taken. So I definitely do like primary care for sure. And then some online resources as well. There's a lot of information online. I think even with like AI stuff that will give probably some pretty good information about how to best treat wounds. I haven't really looked into it deeply, but I know that some searches I can see that they're doing a lot of the same types of things that we typically would do at wound centers.
Sure.
I would definitely start it with primary care. I think that's probably the types of physician that would normally provide the similar types of services. Probably less frequent visits or focused maybe on that, and
Mhm.
can do certain things, but they could provide a lot of things that would be necessary to get the wound to heal. Some urgent cares, I'll see some patients that have gone to urgent care repeatedly. Usually now, I mean, where I'm at, they're combined a lot of times. There'll be urgent care, primary care, and so there'll be somebody that's seen them multiple times. Usually refer them to us when there's a problem, like they're not healing or they need a debridement, and or there's some other issue that needs to be taken care of. But I think majority of the time they would do a great job.
Yeah, awesome. And
Yeah,
so what about from the physician side? So that's like the patient, if they want to get more educated or need that support and don't have access to it. What about the physician? Because I've had a couple of physicians now, well, two different physicians that have kind of been the managing provider on my
yeah,
and I think both of them are really like open to input. Like if they just didn't know, it's not part of their training. Like they went to school.
yeah,
One of them was for endocrinology. The other one had gone to school for interventional radiology. And so they just didn't have the training, but they really wanted to help me. And especially my latest doctor, like he really was, once I started talking with you and I was like, this is what we're doing, he was like, oh, defer to Dr.
yeah,
Courtney. Like this is amazing. And so
yeah,
he's kind of learning along with the process and he's loved that. And I've been so appreciative that I've had great physicians that really care. And I've also heard from other patients that their physicians really want to help them, but this is the first time that they've ever encountered this. So from a physician perspective, if they don't have the ability to refer out to wound care, but they want to get a little bit more educated, are there any resources that they could go to learn?
yeah. That's a good question. So there is the American Board of Wound Management. They have a web page,
Right?
and they actually have quite a few resources. And they even have for somebody that's quite interested, like online classes or training. They even have like in-person training as well at different sites, where somebody can do like a 2-day course, even where they can get a lot of information for like the basic principles of wound care. So I'd say I usually refer them to the American Board of Wound Management, and they
Okay.
have a pretty substantial, well-known organization, evidence-based, and they go to basically are involved with some of the large meetings in wound care throughout the country. There's a big one in Las Vegas every year and throughout the country too. But the nice thing is they have online resources as well for somebody who's not going to go anywhere. For providers, they can actually just get not only books and resources that way, but even like classes if they want to be certified per se in wound care.
Interesting. Oh, that's wonderful. I didn't
Yeah,
know that resource
yeah,
exists. Phenomenal. Cool.
yeah, for sure.
And is there anything else that you can think of that we could just, share today that an endocrinologist or radiologist may not know, or have we already kind of covered that with the misconceptions that we talked about earlier? Is there anything else that would be really helpful for them to know about wound care management?
Yeah, I think, there's quite a few different little things here and there. I think we covered most of the big ones. I mean, for sure, things that we do, not in your wound, for us, but typically things like regular debridements. That's important for healing to build granulation tissue for typical wounds. It's really depending on the cause of the wound. Like we'll see most of our wounds we're seeing are lower extremity wounds frequently. So we're dealing with different issues. The one thing we didn't talk about as much, but I'll just mention briefly, is the importance of added protein intake and nutrition for wound healing. And so the one thing that people don't quite realize, and it's always surprising to me, but the amount of protein that's necessary for building granulation tissue is quite substantial. So it's recommended if somebody's kidneys are fine, 1.2 grams per kilo, 1.2 to 1.5 grams per kilo per day of protein. And so a lot of times for many patients, especially elderly population, I'm having them drink protein shakes daily or sometimes twice daily. And also there's a product called Juven, Joven, which is an amniotic, sorry, it's a amino acid supplement. So it basically has glutamine and arginine and collagen that are the building blocks for granulation tissue production. So it's usually, I think, helpful, especially for geriatric, for somebody that does not have enough of that in their diet. And so that's like a shake, or actually a powder that you put in either a shake or water twice a day for 14 days. So those are probably like the big ones, but a lot of times it's just depending on the type of wound that they have. So we kind of address that.
Yeah, that was helpful. I remember you giving me that recommendation too. In the
Yeah,
beginning, like, tell me everything I can do.
I know, I know.
And
Yeah,
I'll teach you in, and it kind of tastes like
yeah, it does. Yeah, it's not great tasting. They came out with a new flavor recently, coconut, which is a little bit better, but still, yeah,
yeah, but it
yeah,
wasn't terrible. So
yeah, yeah,
yeah.
yeah,
Well,
for
thank you.
sure.
So is there anything else? We've covered so much, and I'm so grateful for you taking the time
Absolutely.
to go through this. Is there anything else that you can think of that we haven't covered? Any words of wisdom for patients or physicians going through this, or anything else that you wanted to add to
It's
this?
mostly, I would say, just kind of what you've kind of done is basically you have to kind of seek out the treatment. You have to be your own patient advocate. I think a lot of times what I help with, because I'm not knowledgeable about so many different areas, so I'm trying to use my knowledge to redirect somebody to get the right kind of care that they need. So sometimes it's just about trying to find, it's a search. We have a lot of resources these days too. So kind of like what you've done, you kind of search to try to find the type of care that you need. Yours was very specialized and complex and difficult. Others are usually not going to be that complicated. But I think just being somebody's own patient advocate, not taking one provider's, advice as gold, because everybody, can learn from others, and trying to seek out the type of care that you need. Depending on where you're at, there's going to be different providers that I'm sure would have various knowledge in different areas. So getting second and third opinions and seeking out, the type of care that makes the most sense for you. also like online stuff. I know it's kind of crazy, drives doctors crazy. People look things up online, and I'm sure ChatGPT and all the online stuff, but there is some valuable information in there, and trying to figure out which one is truth and which one makes the most sense, and presenting that to the different providers, somebody that can work with them. That's probably the best advice. That's what I would do for myself, I guess, or family. So,
No, that's so helpful. I love that you said that. And I just want to piggyback on that because as I'm working with these different patients that are going through their own ruptures and they've asked questions or this doctor, blah, blah, one of the things that I keep going back to is like, trust yourself. Like, does it
yeah,
feel right? Does it feel safe? Do you feel
yeah,
safe around this physician? Are they listening to you? And that's
yeah,
one of the biggest things for me is like, is the physician just doing what? And not, I think most people go into medicine really like wanting to make a difference and wanting to help. And they're so smart and so valuable. And I so value all of the experience that everyone brings to the table. But I think, sometimes can people, whether they've had a bad day or they're just in the flow of things, it's like just making sure that you value and honor yourself enough to kind of get a second or third opinion if you need to, and find physicians that actually care and are there for you. And I think I've learned that lesson the hard way. So
yeah.
this time around, I just feel like so blessed. I feel like I have the best doctors in the whole world that like are so knowledgeable like yourself. I mean, you're the medical director of the wound care facility. You just know so much. And I'm even now, I mean, I've worked with you for almost a year on a weekly basis, and today I'm
Hmm.
learning new things. So
Yeah,
such a wealth of knowledge. And the other physicians that I've worked with too, before you decide on an RFA doctor or a wound care doctor or whatever, like feel free to get second opinions or see how you feel with different doctors. And I recently was working with a patient. She had gone to the hospital. They didn't have anybody in her country that specialized because she actually had to fly to another country to have RFA. So when she had the rupture, there was nobody that had performed RFA or knew what to do. And some of these doctors were doing things that just didn't feel right. And so, just encouraging patients to advocate for themselves and to, to listen to their own bodies. And of course, take in the medical expertise and knowledge and,
right.
welcome doctors. But just, I feel like the comprehensive approach and just the collaboration has literally made a world of difference because when you're going through something like a thyroid nodule rupture, which is so rare and unique on its own, it's not just the physical, it's also kind of the shock of the emotion of it. And so having like a provider like yourself who really cares, who takes their time, who answers all of my questions without like looking at their watch, like you've
Yeah.
you've always been so patient and taken all of your time with me. And it's just like it makes such a difference in the care, the way that yeah, just the whole process. So I'm just so grateful for you and all of your knowledge and wisdom and
Thank
that
you. No, I appreciate that very much. And I think, this is a valuable resource to others, what you're doing, because this is such a rare thing, like we talked about, and having somebody, if somebody, this happens to somebody, it's a scary thing. It's something that definitely, they don't know where to go or what to do. Maybe the person that, had done the procedure initially is very uncomfortable because they've not seen it themselves. So having this as a resource, that's going to be really valuable. So thank you for providing that to the people that have this unfortunate thing happen to them. So
yeah, thank you. And the one last thing is that I've noticed that if they are feeling uncomfortable, one of the things that doctors will regularly they then want to refer to surgery, which I've
yeah,
found now is not necessary. Even in the extreme cases, we've still been able to shrink my thyroid. I'm still, getting improvement. And I actually saw a surgeon last week who was like, "I don't think you need surgery anymore." And I'm like,
yeah,
"Oh, that's amazing." So.
yeah,
uh,
yeah,
so for just hope for other patients too is that if you have a rupture and they recommend surgery, if it still doesn't feel right, still feel open to explore your other options. That every doctor has different perspectives, and just listening to yourself. And I want to be an example that it may
yeah.
sometimes it might be necessary. I don't want to either, but in my case, I was still able to avoid that, which has been remarkable for me, and I'm so grateful.
Amazing. Yeah, those are I absolutely agree with that 100%. I think it's definitely something where, because it's something that's not very commonly seen, that is the automatic, deferral. I think as time goes on, that'll change. And when knowledge changes, then it's kind of like going from, open gallbladder removal to laparoscopic
Mhm.
like robotic procedures, it's the same type of thing where once there's information out there and there's a comfort level that's different because they know they've had a number of people that have had successes,
Mhm.
then that changes the treatment overall. So yeah, again, that's amazing. Thank you for all the information you're putting out there.
Yeah. And thank you for all of
All
your
right,
so, so
sure.
great.
Absolutely. Absolutely.
All right.
Yeah.
Corey,
All right.
thank you so much again. And
Pleasure,
so appreciative.
pleasure talking to you. You take care. We'll see you soon.
Okay,
All
you too.
right. Take care. Bye bye.